Thank you so much, Laura. So thank you very, very much, Helmut, for this wonderful presentation. It was very educational. Now I would like to share with all of you and interact with all of you on a case which came to our clinics in 2016. This lady, who was a cleaning lady, came to our department, and she was actually sent by the vascular surgeon to us. In Belgium, vascular surgeons refer to rheumatologist patients who have the Raynaud's phenomenon. The medical history of this lady is that she's a cleaning lady. She likes to knit, she likes to crystal dye, and she smoked between 95 and 2015. So until 1 year before the consultation, she has 20 pack years of smoking. She doesn't use alcohol. She has one child. She had a Hashimoto disease, and she had a gastroscopy executed which showed a limited diaphragmatic hernia without any signs of gastroesophageal reflux disease. She had a mild enteritis for which she got PPI. When she's on the consultation, she mentions, except from taking L-tiroxine, she takes amlodipine, recently started for her Raynaud's phenomenon. In June 2016, she comes to the rheumatologist for the first time with a recent onset of Raynaud's phenomenon. This is why she was sent to us by the vascular surgeon. She mentions to have a non-NIA class dyspnea, which limits her daily activities as a cleaning lady, but it's stable dyspnea. She has on clinical examination diffuse cutaneous skin involvement with a modified Rodden skin score of 23/51. On chest auscultation, we find bilateral Velcro-like crackles on the basal sections of the lung. As Simona taught to all of you, in systemic sclerosis patients at baseline, we execute several investigations, always in HRCT, always pulmonary function tests, 6-minute walk distance, and echo of the heart. So, and this lady referred to us with Raynaud's phenomenon and diffuse cutaneous skin involvement. We have on lung function FVC of 85% at baseline. A DLCO single breath of 57. DLCO over alveolar volume of 81. She walks 483 meters and she does not desaturate after 6 minutes. At baseline, this lady has a tricuspid irritation of 2.3 meters per second and no other signals, no other indirect signals which might point out to pulmonary hypertension. This is her baseline in HRCT, and I'm so happy we have an expert here who will explain to us what he sees on the baseline HRCT. Helmut, can you please comment to us?
Yeah, sure. This is a typical case in that context. What we see here in a patient with systemic sclerosis. Here, let's start off with the image number 1, where the asterisks are. This is what I would call fine reticulation in the anterior upper lobe. And similar changes can be seen and more extensive here in the lower lobes of both sides. This combination of findings would lead me to the diagnosis of a non-specific interstitial pneumonia. And this combination of the anterior upper lobe and the posterior lower lobes, that's very, very typical for that. If you now ask me if there's an inflammation still going on, I can't tell you that. That's beyond the possibilities of a CT, but the diagnosis would be non-specific interstitial pneumonia.
Thank you so much, Helmut.
Yeah.
Now I will scroll through the HRCT, and maybe Helmut still wants to say something afterwards.
Yeah. You see here, it's quite fast. We are radiologists are fast in diagnosing, but not so fast. But what you see here, in that context, it is exactly what I told you here. It's nicely seen, combination of reticulation and ground glass. So in that clinical context with systemic sclerosis, that's what I would call a non-specific interstitial pneumonia.
Thank you so much, Helmut. Helmut, do you agree that at the beginning, when we saw this lady, we said that she had limited interstitial lung disease?
Yes, that it was quite limited, yeah.
Thank you so much, Helmut. So, a question to the room, what do you think that we did in 2016? This was a lady who had diffuse cutaneous skin involvement, SCL70 positive, perfectly acceptable lung function with an FVC of 85%, DLCO over alveolar volume, which was high enough, no desaturation on 6-minute walk distance. We discussed with our pulmonologist and our multidisciplinary team then, can we put this lady in a randomized controlled trial for her early diffuseness of skin involvement? And the multidisciplinary team agreed we put her in a randomized controlled trial. This is the lady when we started, and Helmut very nicely explained to us what we saw on the HRCT. A lady with limited interstitial lung disease on HRCT and a modified Rodden skin score of 31. So we felt safe to put her in a randomized controlled trial in which probably also took part, a trial in which we assessed the effect of tocilizumab on skin. In June of 2016, her FVC was 85, as we saw. After 24 weeks in a randomized controlled trial, she got placebo, but of course we didn't know that while we were treating her. Her FVC dropped to 78. Her modified Rodden skin score remained more or less stable. Her DLCO single breath remained stable. At 48 weeks in the randomized controlled trial, her FVC dropped to 73. Her HRCT, which I won't show now, still showed limited interstitial lung disease, but her FVC had dropped from 85% to an FVC of 73%. At that moment, this lady went into the open label extension and did get anti-IL-6. So between June 2017, already 1 year after this lady came to us, and December 2017, she was in open label extension with anti-IL-6. She did get the treatment, but she got further drop of FVC and she became more symptomatic. She went to a NIAC class 3 dyspnea. At that very moment, we added on other immunosuppressive therapy, more specifically mycophenolate mofetil. She got a stabilization of FVC and stabilization of symptoms. In 2019, for social reasons, this lady declined further treatment. And I would like to show you her last CT, even though she had gotten stabilization of FVC and symptoms. Helmut, could you please teach to us what you see on this HRCT in 2019?
Yeah, we do not have now the one-on-one comparison, but I think you could well remember that this was a minimal findings in the chest CT. But you see here, this is now much more extensive. You see here in image number 1, in the anterior part where the hysteresis are, you see some much more reticulation, and this is much more pronounced than in image 4 and 5. You see a lot of reticulation. The whole lower lobes are involved. It's not just a minimal disease anymore. And I assume that you're not that familiar with the CT interpretation, but if you look here at the fissure, which divides the lower lobe from the middle lobe here, there's a significant loss of volume. Yeah, exactly here. There's a significant loss of volume, just showing how progressive that disease is. That's not just a minor fibrosis, that's now involving the whole lower lobes. And yeah, progressive progression.
Thank you so much. I will run you through the fast run through again, and you can tell me when I can stop.
Yeah, stop. Yeah, here.
Oh, I will stop again if he doesn't let up.
Oh, yeah. And if we go a little bit lower now, you can see the lower lobes are completely involved. This is at least 70% of the lung, 60% of the lung are involved here in this patient. You just need to know that the lower lobes make up around 50% of each lung. So if the lower lobes are completely involved, like in this case, it's already 50%, but there's also, in addition to that, you see in the lingula, the lower lobe, and the middle lobe, and the upper lobes. So that's a substantial involvement of lung tissue here in this patient.
Thank you so much, Helmut. So this is the overview of the case. And I just show this overview because nowadays, of course, we would treat our patient differently. Nowadays, if a patient comes to us with a diffuse cutaneous skin involvement, and even if they have minimal involvement on HRCT, would immediately, and I've copied again the ACR guidelines here, start with mycophenolate. And as soon as the patient progresses, we would add on Rituxan. And with further progression, we would add on nintedanib nowadays. So our behavior of these patients and management has changed a lot over time, and we would be far more aggressive nowadays than we were in 2016. So the conclusions of this first case between Helmut and I is that we had a systemic sclerosis-related interstitial lung disease with limited interstitial lung disease at baseline, but risk factors, SCL7 positivity, diffuse cutaneous skin involvement. Because we didn't treat this lady, she had progressive and increasingly fibrotic disease, increasing dyspnea, decline in FVC, worsening of extent on HRCT, and increasingly fibrotic features, as Helmut showed to us. So in spite of standard of care, she progressed. We initially had put her in a randomized controlled trial for her skin involvement, but she got placebo. We added on CellCept, but too late. Nowadays, we would start earlier with more aggressive therapy and add on anti-fibrotic therapies. Helmut, do you also still have a case?
Oh, yes.
Wonderful. Then I will stop sharing and you can share your case.